So this is my declaration of interest. I don't have any conflicts in presenting the session, but I do think it's something we need to be clearer about. And I'm going to look at reasons for concern in lower limb conditions, what can we do as healthcare practitioners, and how do we get more information and advice. And these are the sort of phrases that you'll all hear in your clinical practice all the time, about patients who are constantly in pain, describing their legs as murder, being on fire, can't get any relief, don't know what to do with them, and some, serious comments about I'd rather be without my leg or without my legs. That's how serious some people view their conditions. And so, as I said, we want to start to think about looking through the legs as if they were a window to allow us to think about what else might be going on. So just setting the scene around chronic edema. So in a study by Professor Moffat, who joined us last night, which was a lovely surprise, in 2019 with her colleagues, she looked at the prevalence and risk factors for chronic edema within community nursing caseloads. And there were 2,541 patients included, so a very significant number, and 56.7% had chronic edema. So a very high percentage, not surprising to most of us in clinical practice. But that those patients had a greater incidence of diabetes, heart failure and ischemic heart disease, and peripheral arterial occlusive disease. But by far the greatest association was with a wound, and yet we still talk about chronic edema and leg ulceration as if they're two completely separate things. And cellulitis affected around 25%, and 47.8% had a concurrent leg ulcer. And then reduced mobility and obesity were much higher in those patients with chronic edema. So we're talking about patients who have multiple comorbidities, serious complexity, and we no longer see people with one modality. It's now multimodality and polypharmacy. So if patients describe painful legs or pain in their lower limbs, then are we talking about something that's already known? Is this one of their comorbidities that we already know about? Is it something that they're aware of and being managed for in primary or secondary care? Or could it be indicating something more acute? So we need to be undertaking our pain assessment, as we know, using visual analog scales. What's the duration of the pain? What's the type, including a description? Which healthcare professionals have already been involved? Many patients have previously been through pain management or other systems. What analgesia have they tried, and what have been the effects of those? And we just don't have time in clinical practice to undertake this extensive pain assessment often. But what it can lead us on to thinking about is what might be the cause of their lower limb pain. So peripheral arterial disease, a form of cardiovascular disease affecting the blood vessels, usually due to the buildup of fatty deposits. We know that many patients will have no symptoms, but other patients will have symptoms. Risk factors include smoking, diabetes, hypertension, hypercholesterolemia, increased frailty and age. That's starting to define most of my caseload. I don't know about yours, but already we know their risk factors are high. So intermittent claudication may be something they're complaining of. Pain in the calf when walking could be similar to cramp, which reduces the distance they're able to walk, sometimes described as being worse when they walk uphill, but then when they stop and rest, that pain ceases, but then returns when they start to walk again. Usually no issues when they stand and can be worse in one leg. So if patients complain their legs are murder and are killing them and they can't walk far, is it because they've got osteoarthritis, which is known and being managed with an anti-inflammatory, or is it something different? If that's more severe, it may be described as rest pain, so pain at rest in the foot or the leg, which may be worse at night. So we have to try and use our differential diagnosis around restless leg syndrome, around other neuropathic pains, and then around this type of rest pain, which patients can describe as neuropathic in nature, so burning or tingling and numbness. Hanging their limb out of bed may give short respite, but they sleep poorly, sometimes choosing to sleep out of bed in a chair to get comfort. And I'm not going to talk about critical limb ischemia because you've got a fantastic presentation coming up from somebody far more knowledgeable than me, but that might be that this pain is associated with discoloration in the lower limb, ulceration, paler skin, or weaker or wasted muscles. So our assessment process on top of our pain management assessment is then a vascular assessment, including pulse palpation, auscultation and Doppler waveform, and then ABPI or TBPI, whichever in your practice you're used to using and that fits in with your significant group of patients. We need to be undertaking our vascular history as well. Have they had any procedures done? Quite often in the patients that we're seeing, their varicose vein treatment was years and years ago, sometimes 20 or 30 years ago. So we're needing to find out about those things. Did they have changes when they were pregnant or other things, as we've heard about the risk factors? And how many of you are undertaking vascular assessment and identify irregular heartbeat, AF, other changes that we're then referring on for management? So actually what we do is really using that window into the legs to use them as a viewing platform to see what else might be going on within the deeper systems. DVT we've heard about a lot this morning in the presentations. So blood clot in the vein, usually in the legs. We know that risk factors include increased age, obesity, smoking, previous deep vein thrombosis, patients on hormone therapy, cancer and heart failure, and varicose veins. Again, when we start to put all these risk factors together, there's not many people that don't have something alongside what we're seeing. We know that things like being on bed rest for an extended period, having undergone surgery, these are other things that increase patients' risks, as well as travelling. And we have significant condition-specific risks as well. But the pain and the swelling can be really difficult to use our differential diagnosis skills in a patient who already has chronic swelling and may have asymmetry. So one leg may always be larger than another. So it can be really, really difficult then to extrapolate what's going on. We heard earlier about other causes of redness in the legs. Redness, acute onset lipodermatosclerosis we heard about, unilateral, red, hot, not spreading within the calf. Could that then, our differential diagnosis, be that we're thinking DVT? Most definitely, it's very difficult to find out what's going on at that time. So we need to undertake a Wells score. We need to be using our ambulatory care referral process for making sure that patients undergo appropriate investigations, including D-dimer and then duplex scanning. The British Lymphology Society, who I'm a trustee for, have a paper regarding the management of patients post-DVT with compression. It's something the society gets asked about all the time. How soon can patients be put into full compression after they've had a DVT? There's a lot of urban myths out there about the time that needs to have gone past or expired, how quickly after anticoagulation and investigation. So if you have questions about that or are interested in developing local policies, you could use this paper to develop that, and BLS has a stand here today if you'd like to find out more. So if patients have swollen limbs and shortness of breath, what could that be showing? So we have patients with chronic edema who will come to their appointment or will contact the service to say that they are now swollen all over, that their lower limb swelling has increased, it's worse than ever. But it's now affecting their abdomen, it's now affecting their hands and their wrists or their arms, and their shortness of breath is worse. They may have, known to have COPD or asthma concurrently, but that their shortness of breath is worse, and that they've now started to sleep sat in a chair because they're struggling to get their breath or to get comfortable or to lift the sheer weight of their limbs in and out of bed, and that then they've developed lymphorrhea, leakage of lymph through the skin. And again, we need to be using our differential diagnosis to exclude heart failure as a cause of this increase in edema. And by describing the symptoms as significantly as this, it might take you quickly and easily to think along the lines of excluding that. But if it's milder changes, it doesn't always. So thinking about undertaking an NT-proBNP blood test, very simple and easy to get done in most community settings, it can actually tell us whether or not the patient does have a degree of heart failure exacerbating their swelling. And Wounds UK have a stand here today, and the best practice statement for when and how to apply compression in patients with heart failure is a really key document to support your practice, because again, there are more urban myths about when it is appropriate to use compression in patients with heart failure, and which patients and what their ejection fraction should be. And if you're not a cardiology expert, that can be a bit of a minefield. So definitely use the documents out there to support your practice. So I'm going to touch on a case study here, thinking about shortness of breath and swelling. So John was a 63-year-old gentleman who came to his chronic edema appointment, routine appointment. He has obesity, hypercholesterolemia, hypertension, is independently mobile, usually with a stick, and he has lower limb swelling, which is symmetrical and bilateral. His limbs were measured, as is part of our usual process, and his right leg had increased very, very marginally in limb volume. He was wearing his garments with good effect. There was no redness, no pain, no thickening in the tissue, and certainly no increased difficulty in his mobility. And he was arranging his next appointment when he stated he was going to contact his GP when he'd got home, as he thought he might have a touch of bronchitis. And when asked about that, he said that he had some mild chest pain, but no cough, no other symptoms, nothing else. And he was referred to our ambulatory care department from that outpatient appointment, had a D-dimer and an ultrasound, and actually had a PE. So that slight increase in right leg limb volume showed that there had been a DVT, and that he did have a PE, and he was told that he was very lucky to have been identified as that. So it would not have been something routinely in a community setting or within the clinic that would have been picked up on. So it's using those lower limbs to try and identify where there may be an acute cause for the swelling. Cellulitis may be the next thing that we're thinking about in looking at the lower limbs and thinking about our differential diagnosis. So if the legs are red, and they're swollen, then it may be that we're thinking about an acute spreading inflammation of the skin and subcutaneous tissues characterised by warmth, swelling and erythema. That's the British Lymphology Society's definition of cellulitis, which is slightly different to cellulitis in the absence of swelling. And we're looking at a very serious infection, very rapid onset, very painful. Of course, it can be anywhere on the body, but the lower limbs is very common. And we know that blood tests are not perfect, and we don't always have that information to inform our decision-making process. But there may be, and usually is, a port of entry into the skin. So if patients have got an underlying skin condition, psoriasis, eczema, or we talked earlier about nail infections, it may be that that actually was the cause or the port of entry for that infection. We know that the appropriate management of cellulitis in patients with lymphedema may be different to other clinical situations. So if your patients have got chronic edema or swelling, it is important to think that their likelihood of developing an infection and the way in which we manage that may be different. So there can be a far more rapid onset, and also it may be that they have an atypical presentation. So some patients will have rashing rather than advancing or spreading block colour redness. Generally, it's still streptococci, but we do see some more Staph aureus infections. And actually, some patients with chronic edema don't have a very significant high temperature when they experience an episode of cellulitis. They may have increased swelling, and that might precede any other redness or any other changes on the skin. And it can be very difficult to identify. So again, the British Lymphology Society, along with the Lymphoedema Support Network, have provided guidelines for the management of cellulitis in patients who have swelling. So this is helping to identify what types of antibiotic treatment may be necessary. We know that flucloxacillin is frontline generally for cellulitis, and that would be the same in our group of patients, but for a prolonged period. It advises when hospital admission is necessary, if that is not glaringly obvious, and also when prompt treatment including other non-antibiotic therapies are important to avoid sepsis or other any damage to the lymphatic system. So antibiotics for a prolonged period in patients with swelling, so it should always be 14 days, whereas guidance for cellulitis would otherwise say 7 days. There is a significant rate of early recurrence for patients with swelling. So a 7-day course will often result in recurrence of the infection, and then patients will describe having had cellulitis multiple times, but actually it was the fact that they had underlying swelling and weren't given a long enough course of antibiotics. And skin changes may persist, so it may be that their acute infection has subsided, but there is still redness or staining present for many months or even years afterwards, but that this does not require long-term ongoing antibiotic therapy. Some patients will need antibiotics to keep at home, or a rescue pack, similar to those patients with COPD that we're more used to managing with rescue medications. And the document explains the reason why this is important and justification, which has been developed with microbiology and general practice to make sure that it doesn't conflict with local practice and local advice. So we know that patients who've had an attack of cellulitis and then are at risk should then carry keep at home antibiotics and keep at home. And actually the intervention or the interaction with statins is also highlighted, and the changes that need to be made. Many of our patients will be taking statins and polypharmacy, as we mentioned. Antibiotics may be started by the patient immediately to try and prevent any severity of symptom and further damage to the skin and subcutaneous tissues. And if there is a lymphedema service local to you, then a referral on or discussion with them is often recommended to see whether that patient is using rescue medications too frequently or whether that needs reviewing. The document also talks about prophylactic antibiotics, and there is a huge amount of antimicrobial resistance and stewardship that we need to be mindful of. Hence, microbiology have been involved in the development of the document, because we know that there is more resistance, more prevalence of resistance, and we need to be really careful about the use of antibiotic therapy, specifically prophylactic antibiotics. But if patients have 2 or more episodes of acute cellulitis, then the document would recommend the use of prophylactic antibiotics, a broad spectrum penicillin V generally, which we use clarithromycin if patients are penicillin sensitive, or again a change if patients are on statin therapy. We should always be reviewing prophylactic antibiotics, so patients shouldn't be on them indefinitely. The document talks about 6 to 12 months initially, and then review that. And it also looks at if patients have a breakthrough infection or a breakthrough cellulitis while they're on antibiotics, how to manage that, and how patients should be advised to stop taking their prophylactic antibiotics while they then have an acute course of antibiotics. So the document gives a very clear guidelines on when prophylactic antibiotics may be useful. And again, it sometimes is necessary to open those discussions with general practice and microbiology locally to see what the recommendations would be. So if you're meeting resistance, it's not enough to say, oh, well, we asked the GP for prophylactic antibiotics, or we prescribed this, and then microbiology said no. Actually, what we should be doing is opening those discussions with the documents that have been developed nationally to support those discussions, to make sure that we do get patients the right care. But a systematic review by Patel and the team in 2019 did show that 1 in 3 patients admitted from the emergency department with suspected lower limb cellulitis actually don't have an acute infection, and they're given a completely different diagnosis on discharge. So they may have actually undergone unavoidable hospital admission, unnecessary antibiotics, which may have been intravenous. We heard in Marco's discussion earlier, that's often the case. And because of the difficulty in differential diagnosis, it's not surprising that antibiotics are given, and that when they looked at this study, there were no robustly developed validated diagnostic criteria or tools for use in clinical practice. They went on, the same group, to further look at a scoping review of lower limb cellulitis, and looked at the diversity and misdiagnosis of cellulitis and what other conditions were frequently being managed in this acute cellulitis pathway. Level in 2011, previously in their very large study in Norfolk and East Anglia, had looked at patients being put on a standard cellulitis pathway without being given that process of differential diagnosis. So they had a different way of managing cellulitis in their acute trust, in that all patients were seen by dermatology to try and exclude some of those other dermatological or vascular conditions that we saw some beautiful clinical images of earlier. And recent research by O'Brien and White has shown that lower limb conditions continue to be mismanaged and misdiagnosed. And because we're only looking at the outside of the leg, we're looking at redness, we're looking at swelling, we're looking at pain, it's not surprising that it's very difficult to say what's happening. And if the patient's complaining of pain and complaining of feeling unwell, we're trying to look at what matters to them. We've heard about person and patient-centred care. And so it's quite understandable that things are easily misrecognised. So red legs causes a significant amount of misery. There may be associated pain, tenderness, burning, throbbing. The skin sensitivity may be very high. Patients saying they can't even stand the bedclothes on their legs. They're so sensitive. The skin may be very fragile and shiny. They may have been using topical steroids for other conditions for some time. And this real sensation of not being able to cope or deal or manage these symptoms. They're so severe. So red legs is where there's bilateral redness below the knee. So when we heard earlier about acute lipodermatosclerosis, that was unilateral. We're trying to think about separating redness below the knee that's bilateral and redness below the knee that's unilateral. If it's unilateral, there's far more likely to be an acute cause, similar to DVT, similar to cellulitis. If it's bilateral, then it's more likely there's a chronic cause, which may be vascular or dermatological in nature. There may be associated warmth and tenderness, but no systemic upset or malaise. If we think about the vast majority of the patients that we see, not many of them are fit and well and say that they feel great. So actually, how difficult is it to extrapolate what bit is related to their lower limb condition, or do they just generally not feel well with their comorbidities? They may have normal CSP and ESR if you're lucky enough to have access to those blood tests. And a diagnosis of cellulitis cannot be solely based upon the appearance of the legs being red. So this is often what's still happening, is that patients will be seen in clinic and say, I've had 6 or 7 episodes of cellulitis this year. I've had flucloxacillin 6 or 7 times for a week each time, and it's had little or no impact on the redness. And when you ask about the symptoms, they were always bilateral. So both legs were red, but they were inflamed and sore, and the GP gave antibiotics to improve the symptoms. It was always done with the right thought process. However, we know that inappropriate or overuse of antibiotics is responsible for resistance. We all have a responsibility around that, and therefore antibiotics should never be prescribed just in case. We're then opening patients up to a very poor experience, less than optimum outcomes, and duplication, because patients are being seen by numerous individuals in numerous different settings for the same outcome. They're not actually moving forward in their red leg management at all. So the British Lymphology Society has developed a red legs pathway in order to ensure correct identification of the cause of the redness in the legs. So this is looking at all of those venous conditions that Marco highlighted so beautifully earlier, thinking about some of the dermatological things, thinking about things that are largely chronic in nature rather than acute. So its aim is to assist differential diagnosis, to improve patient experience. It covers failure to respond and atypical cases. It's designed to give practical management strategies. So it looks at patients who've got leakage of lymph through the skin. It looks at different skin measurement and the way in which we need to manage that. And the idea is that it supports when we don't prescribe antibiotics, because once a patient's been told they've had cellulitis, usually by one of our medical colleagues, it's very difficult to then say, oh, I don't think you did. Because somebody being told you've got cellulitis, when we come along and say, oh, I don't think you had, it's very hard to unpick or to say, I actually don't think that's the case, because nobody thinks that your expertise is enough to undo what's already been done. And they had antibiotics for it, so it must have been that. So actually this is designed to support that. So although it's designed for healthcare professionals, we use it to support our practice. And the Legs Matter campaign have very kindly allowed us to use their logo with the pathway. Working with Legs Matter has meant that we've had close links with the College of Podiatry. And when we talk about red legs and unilateral and bilateral causes, one thing as nurses and physiotherapists, which the vast majority of us are within the British Lymphology Society, we were not thinking about primarily was Charcot-Foot. And this rare complication of diabetes, which is related to neuropathy, definitely is very serious. And our podiatry colleagues have asked us, as part of the red leg pathway, to look at, within our acute causes, which are also listed on there, Charcot-Foot, because the early signs are unilateral swelling, pain, redness and heat in one foot. And this wouldn't be something as nurses that we would have primarily been the first thing to think about. So again, it's made us much more thought-provoking in our differential diagnosis. And the red leg pathway will be amended to reflect this and some other changes, including the difficulty in identifying redness within darker skin tones. So we know that the terminology we use around redness, erysipelas, and cellulitis often talks about redness, which can be much harder to identify in different and darker skin tones. So the red leg pathway may change its name and it may change its information, but hopefully it will still be a really practical tool for use in our clinical areas. Psychosocial factors can also be something which can, for patients, highlight the fact that they feel that their lower limbs are killing them, and certainly the altered appearance of all of the clinical photographs that you saw earlier. If that was your legs, I'm sure we'd all feel that there was a very significant impact on our body image, and that's without some of the ulceration that we've talked about as well. That feeling of being alone, not listened to, not heard, very low in mood and depressed. And then by having this acute or chronic, whichever that might be, condition, which means that it's far more difficult to mobilise because of pain, because of weight of the limbs, because of dressings, leakage of the limbs, inability to get shoes to fit appropriately or appropriate weather, condition-specific shoes, reducing our venous and lymphatic return by reduced mobility, increasing edema, that leads to greater social isolation. And it's only fitting that we're here at the Lindsay Leg Club conference, and that the model is the primary indicator and strong indicator of how isolation significantly affects the patient's response to treatment. And if there's no better way than us promoting that through thinking about what lower limbs can tell us about the legs, this is the one place for us to do that, which is lovely today to us all be together thinking about person-centred care, which has been the driving force behind this. Malignancy, again, may be something that we pick up from the lower limbs. So any non-healing, raised, bleeding, crusting or suspicious skin lesion should be referred on. We've heard a lot about referral on for venous leg ulceration, but actually many patients that we see say, oh yeah, I've had that for 6 or 7 years, I'm sure it's fine, it bleeds and then it dries up and it's fine. And somebody once said it might be something, but so actually we should be making sure that those patients are referred on a 2-week wait. And then our history taking or our assessment, if patients have got lower limb conditions, should include whether they've had a previous cancer. And that might actually have been many, many years previously. So a patient may have had a bowel cancer 20 years ago. They may have had a total abdominal hysterectomy for endometrial cancer years and years ago and be very well. And that's not a factor that's uppermost in their mind. But actually, it may be that their swelling indicates recurrent disease. So that patient may need to undergo investigation for that. So be thorough in your assessment, be vigilant, communicate your concerns to other members of the team, use your skills of differential diagnosis, but recognize that it's really difficult for us. It's really difficult for us faced with that patient in pain with lots of problems to try and solve all their problems, and document all of those thoughts and concerns and explain them to the patient and their significant others. Remember that swelling, pain, redness and heat can all indicate significant health issues that may be acute in nature. Some may be life and limb threatening, and care should be taken to identify the cause of those symptoms by undertaking any investigations that you're able to do yourselves or referring on as necessary, as well as attempting during that wait period to achieve the very best outcomes that we can. So it's not good enough to say, well, it could be this, and we'll have a hands-off approach for that whole period of time while you're waiting, that we should be initiating management to palliate the symptoms even if we're not able to move on to a resolution. To palliate the symptoms according to the patient's priority and needs should still take place at that point in time. You are your patient's advocates. You know that you're really good at that. We heard yesterday, for anyone who was in the workshop about assertiveness, we're not very good at doing that for ourselves, but we're very good at doing it for our patients. And if you wish to keep up to date with more information about chronic edema and managing lymphedema in the community, then please join the BLS as a member. It's free of charge and you get access to all of our resources and a quarterly newsletter. So I hope that you'll find some of the resources useful to support your practice if you're not already using them. Thank you very much.